kind of know who you are, okay? If you don't mind. If you don't want to share it, you don't have to, but this way I get to know you guys a little bit. Okay, it's a big group. It's a big group. Last time I think I had maybe 8 or 9, so it's nice to meet you all. This is you're in your first year, is that correct? How's it going? Good. It's a lot of stuff, right?
Yeah.
How many times do you feel like your brain is swollen, right? You can't fit any more in there? They say you only really use about 20% of your brain, so I'm sure you got the capacity to learn this stuff. So, what time, Ilshad, what time do we go till today? About 4:15, 4:15. So we'll try and compress a lot into about 1 hour. This week, we're going to kind of focus on common topics in emergency medicine, things that if you work in a clinical setting, you're likely going to be exposed to on more than one occasion. We'll do things focused around chest pain, do some stuff around abdominal pain. I have a fun section on orthopedics and that kind of stuff. We have a trauma, we have a pediatric, so we'll see what we can fit in this week. And then Ilshad will be the same group next week for wilderness medicine. Wilderness medicine will do some things that may or may not be something that would be useful in your medical career, but may be useful in your personal life if you travel or you do any kind of expedition work or things, which is a particular interest that I have just because it's kind of practical life stuff. Hypothermia, hyperthermia, altitude-related stuff for any of you guys who may travel in the future. There's a lot of interest in altitude medicine. So anyway, we'll do some of that. I have a lecture on venomous sea creatures, which any of you guys swim down here, guys or gals swim. There's a lot of good stuff on that. We've been snorkeling the last couple of days and seen some interesting stuff. And yeah, so anyway, we got a busy 2 weeks, so we'll start with that. Anyway, so today we're going to talk about atraumatic chest pain. When we do our trauma lecture, we'll talk a little bit about trauma to the chest, but today we're talking about atraumatic chest pain. Because it's really important in emergency medicine that when you go in to see a patient and you are first seeing them, that you have an open mind to what the potential diagnosis may be. Not all chest pain is a heart attack. Not all chest pain is musculoskeletal. There's a wide range of conditions that can cause atraumatic chest pain. There's something in medicine that you can get. Sometimes you can get tunnel vision, where you focus on one diagnosis and you fail to consider other possibilities. And oftentimes, as you go down one of these diagnostic pathways, you miss the opportunity to stop and pause and think about other things that may be going on. Okay? I didn't introduce myself. My name's Dr. Patrick Broderick. I've worked in emergency medicine since 1986, so that means I'm old, but it also means I have a lot of experience and I've seen a lot of different things over the years. So some of this, as we go through, I will try and give you some real-life clinical scenarios that I've encountered in my personal career or that some of my colleagues have had. We'll do this in like a case presentation way, because it's always, rather than just kind of lecturing about certain conditions, it's better to kind of relate it to a patient. And I would please ask that we make this interactive, all right? You don't want to hear me talk for an hour straight. I want feedback from you guys. So as we're talking, I'm going to just kind of, point to you and say, what do you think about this, okay? Any questions so far?
No, we good.
Okay. What's your name?
David.
David. Nice to meet you. You want to read this out loud to everybody?
So,
If you can see it, okay.
a 28-year-old woman with no medical history presents with chest pain for 2 days. The pain is increased with deep breathing. Vital signs are within normal limits. She takes estrogen-based oral contraceptives for birth control. Examination reveals a well-appearing woman with a normal heart, lung, and extremity examination.
Okay, so this is a fairly typical presentation. So, relatively young woman, pleuritic chest pain. When somebody says increase with deep breathing, the term for that is pleuritic chest pain. Hurts when you breathe. What are normal vital signs? What's normal blood pressure?
128.
120 over 80. What's normal heart rate for an adult male? Adult male or female?
60 to 100,
60 to 100. And normal respirations?
close to 20.
Up to 20. And obviously temperature. A temperature under 100.4, anything up to 100.4 is normal. So when people say I have a temperature is 99.5, it's not a temperature. 100.4 is the cutoff. I'm talking Fahrenheit here. So anything in this history, David, right? Anything in this history that David just read that rises to a concern?
So
What is there in the historical aspect there that makes you worry a little bit?
I think just estrogen-based oral
What does estrogen put you at a greater risk for?
Hmm?
What does the estrogen-based oral contraceptives put you at an increased risk for?
So, for example, deep venous thrombosis or other.
Right, so estrogen-based contraceptives increase risk for VTE, venous thromboembolic disease. Add smoking on that. I don't think they say that she smokes here, but smoking and birth control are a bad combination for blood
And
clots.
also, for example.
The fact that she has normal physical exam, normal vital signs, that's kind of comforting, right? If you have a patient that has abnormal vital signs, you need to be able to figure that out and explain why that is. Let's say she had a resting heart rate of 105, and you do the workup and everything's fine, but she still has a resting heart rate of 105. That's not normal. You have to be able to kind of, maybe she, somebody may say, well, maybe she's just anxious or she's nervous. Yeah, maybe that's the case, but abnormal vital signs, number one, need to be rechecked, and number two, need to be explained. You need to document why you either are or are not concerned about that. Okay, so we'll go through a couple of things. Oops, sorry. Okay, so if I said to you, what's your name?
Michelle.
Michelle?
Anusha.
Alusha, nice to meet you. So, if you were examining this patient, do any of these things stand out that you might want to do? Such as a pulmonary embolism rule-out score, or would you jump to a invasive CT with CT angiogram of the chest? That's dye, a lot of risk associated with that. Any value in an echocardiogram? Sending a D-dimer. Do you know what a D-dimer is?
That indicates the properly.
Yes, so it's a marker of active clotting going on. So you can see that there's some diagnostic things that you would want to consider. So we have to kind of decide where you're going to go with this. Am I going to jump to do some invasive imaging? And let me tell you something about intravenous contrast, any angiograms of this or that. They are not benign. There's a certain percentage of people that are going to have kidney injury with contrast, particularly if they're older or dehydrated. Not in this particular case. There's a certain amount of people that are just going to have a reaction to iodinated contrast. So you don't jump into these tests without having a reasonable amount of certainty as to what's the best course of action to take. Okay, so what we do with cases like this, you try and put somebody, and this is applying to this case, but it's also in other types of cases. You put them into a risk stratification, either low, moderate, or high risk. So if somebody's high risk, you may go down one diagnostic pathway. If they're low risk, you may go down another diagnostic pathway. So you first need to determine if a patient's low, moderate, or high risk. And there's certain scoring systems that you can do. There's something called the Wells criteria, which we'll go through. The D-dimer can rule out a VTE, venous thromboembolic disease, with a negative D-dimer. If it's a low-risk patient. If you have a high-risk patient, a negative D-dimer, it's probably going to make you feel better, but you still need to do a little more diagnostic study. So in this particular case, we would not necessarily do a D-dimer because, as you'll see, she has a risk factor. What was the risk factor?
estrogen.
Yeah, the estrogen.
Based.
So that puts her in a higher risk group already. So she falls into this, a moderate risk. Let's get to the next one here. We'll show you this one. So these are, I know it's hard to see, I apologize from the back. This is what's called the Wells scoring criteria. These are things you will become more familiar with as you do your 3rd and 4th year clinical rotations on a medical service. But basically, you want to risk stratify those patients by looking at things like, do they have physical findings consistent with a DVT? What's your name?
Millicent.
Melissa?
Millicent.
Millicent, beautiful name. What would be clinical signs of a deep venous thrombosis? What might you see in somebody who has a blood clot in their leg?
Okay, so for blood clot in their leg, you can see the veins.
Mm-hmm. So you might get a palpable cord
Yeah.
if they had a palpable, blood clot or a palpable superficial. Most of the time with DVTs, deep venous thrombosis, the examination of the leg is going to reveal a swollen lower extremity, asymmetrical. If both legs are swollen, the likelihood is that they don't have symmetrical DVTs. That's probably another cause something causing the swelling. But unilateral leg swelling, pain with palpation of the calf or the posterior thigh, maybe a little bit of rubor or redness. That may be indications of a DVT. So in this particular patient, it was a normal exam, so she doesn't have clinical signs or symptoms of a DVT, so no points there. Alternative diagnosis less than PE. So if in this particular case you pushed on her side or you saw a shingles rash causing this pain, you'd say, okay, there's probably another likely diagnosis. She wouldn't get those points. Heart rate greater than 100, abnormal vital signs, you get points. The point being you roll these up, and then based on the point score, it's going to give you the probability of a pulmonary emboli. You don't need to memorize this stuff, but there's a lot of tools and things that you can do that you can just keep. Like when I'm doing clinical work, I'll just open this up, I'll put the points in there, and it'll right away risk stratify the case for me. So in this particular case, turns out to be a low risk particular case based on Wells criteria. But here's another risk stratification criteria. If any of these are positive, then if they're all positive, meaning no estrogen use, no hemoptysis, normal oxygenation, that'll put the person into a low-risk group. In this case, she does use estrogen, so she is not in a low-risk group. So my point is, there are these various tools that you can use to help risk stratify. This happens to be as it pertains to pulmonary embolism, but there's a lot of other clinical conditions. Trauma to the head, do they need a CAT scan or do they not need a CAT scan? You put people into risk stratified groups. So in this particular case, the patient takes oral contraceptives, so she does not meet the PERT criteria. She's low risk in the Wells criteria. You would order a D-dimer, because a D-dimer, if it's negative in a low-risk patient, you can pretty much say that she does not have a blood clot. Doing a CT angiogram in a moderate to high risk, you might do that, but in a low-risk case and with a negative D-dimer, you don't need to do that. And an echocardiogram is more for prognostic indicator in a patient that you've diagnosed with a pulmonary emboli, and you do an echocardiogram. If they have signs of right heart strain or a dilated right ventricle, then you know that that's an ominous prognosis, and they may need to go on and get thrombolytic therapy or even some type of invasive clot retrieval. All right, we'll jump to, this is, again, you don't need to focus too much on this, but at the high level, you need to determine, once you've diagnosed a PE in a patient, can I give them anticoagulation and send them home, or do they need to stay in the hospital? So the Hestia criteria and the PESI criteria, again, there's little tools you can use to put this in, helps you determine whether you can send somebody home on anticoagulation, either Lovenox, low molecular weight heparin, or whether you can send them out on one of the novel oral anticoagulants. And you just risk stratify them, and then you make decisions on that. And in this particular case, we determined that it was a low risk. We did the D-dimer negative, so she can be discharged with presumably an alternative diagnosis, but you safely ruled out pulmonary emboli. Don't get too confused about all these criteria thing. You don't need to know the specifics on that right now, but as you get into your clinical rotations in your third and fourth year, there's a lot of tools that you can use to help with clinical decision making. Most of these are evidence-based practice-driven tools, and it gives you assistance in ordering certain type of diagnostic tests so that you're being efficient with resources and not just ordering a bunch of tests on everybody. Okay.
Yep.
What's your name?
Daniel.
Daniel. I don't know if you can see this.
I can see it, I can see it. A 35-year-old man with no significant past medical history presents with abrupt onset of pleuritic left-sided chest pain, coughing, and shortness of breath. He has no fever, trauma, sputum production, or back pain. On physical exam, he has diminished left-sided breath sounds. His vital signs are within normal limits of his age. And then the key elements of the history discussion and then the first diagnosis.
Okay, so we'll show you the chest X-ray in a second. But what in that history concerns you?
Abrupt onset of pleuritic left-sided chest pain.
So abrupt onset versus kind of maybe gradual, and you can explain it. So sudden onset, that should trigger a few things in your mind. Shortness of breath. That other lady had pain but was not short of breath. No fever, no trauma. I mean, if the patient had a fever, you start to go down the infectious pathway, but no fever, no sputum. Usually criteria for a pneumonia is fever, generally sputum, although there's non-productive pneumonias, and some type of symptomatic shortness of breath, cough, etc. So in this particular case, sudden onset of unilateral atraumatic chest pain with shortness of breath. I think I've run out of battery. All right, come on up. Was it Daniel?
Yeah.
Daniel. All right. You got a chest X-ray here, right? I'm not expecting you to be a radiologist. Okay? Anything about this that you want to make comment on? And I'll just tell you a quick little strategy. When you look at an X-ray for, let's say, a chest X-ray, everybody looks at the heart and lungs, right? Start by looking at the periphery. Look at the soft tissue, look at the bones. I can't tell you how many times over the course of 30 plus years you found a lytic lesion or a cyst or some kind of abnormality in a bone or in the soft tissue on a chest X-ray that you were not expecting. So the patient's paying for the whole X-ray, so look at the periphery, okay? Don't forget to do that, okay? So in this case, the osseous structures, clavicles, scapula, everything looks pretty fine there. What's this big thing? Heart. Okay. So we're standing this. This is what's called probably an AP. They took the X-ray from the front, anterior, posterior. Okay. Cardiac silhouette. How big should this be? Does this seem big to you or not big to you?
It should be less than 0.5. So.
Yeah, less than 0.5 of this diameter. So, if we had a little caliper or something like that, we'd measure it. But I'd say the heart size looks pretty normal there. Is this an adequate X-ray? Does it seem like it's done pretty well? I mean, not under-penetrated, not over-penetrated. Looks like a pretty deep inspiration. The only thing I would say about this, you can't see this costophrenic angle here. So you can have a couple hundred cc's of fluid on the left side, not be able to see it because you don't see that. You really need to be able to see all the way down to the angles here.
Would this be like an atypical pneumonia?
Certainly an atypical pneumonia could give you symptoms like that. Probably not as sudden onset, probably not in the absence of a fever. Usually atypical pneumonias are a little bit more indolent, a little bit more indolent. So it takes a couple of days before the symptoms. Usually there's a non-productive cough, something like a mycoplasma or a viral, and you'll see some abnormalities on that. But in this case, anybody, what are we concerned about? Sudden onset, left-sided chest pain, shortness of breath. Young male.
Spontaneous pneumothorax,
Spontaneous pneumothorax. So what would the symptoms of that be?
shortness of breath, sudden onset, no traumatic cause. I mean, I would usually if I saw a young, tall man, that's usually like the textbook description.
Yep. Yeah, so young, tall, thin, somebody with underlying, you can have a seat, Daniel, thanks. Somebody who maybe has a history of COPD or bleb disease, spontaneous pneumothorax. So good suggestion, think in terms of a pneumothorax. What's your name?
Matt,
Matt?
like Matthew.
Matthew, come on up, Matthew. What do you see with a pneumothorax? Or what don't you see with a pneumothorax?
I mean, I would usually, I was looking at the trachea, so I mean, if we look at the airway starting, we have a tracheal deviation to the
So
right.
trachea, well, let me just see if this works here.
Yeah.
So this is the trachea, the airway coming down. Here's your carina. You see one
Right.
bronchus coming this way.
So
and
there's
one over here.
a slight deviation right here, I would say, to the right.
A little bit to the right. That could be the patient's a little bit rotated. If you look at the clavicle heads here, here's the
Right.
clavicle head here. So the patient's probably tweaked a little bit. So I would say probably tracheal deviation. When you see it, you see it. It's over.
Right.
It's not particularly subtle. So
Okay.
tracheal deviation would be something that you might see if someone had a tension pneumothorax. So Matt, right?
Right.
So if Matt were standing here and he had a left-sided tension pneumothorax, every time he takes a breath in, it traps air on that side because he's got a leak. He's leaking into the pleural space. When he exhales, the air doesn't escape the pleural space. So every time he takes a deep breath and air escapes into the pleural space, it's expanding. By expanding, it's doing two big things. It's compressing that left lung, and it's also limiting the return blood supply to the right ventricle because of increased interthoracic pressure. That's why somebody with a tension pneumothorax is going to come in hypotensive, tracheal deviation, extremely short of breath. So in that particular case, so let's say this were a pneumothorax.
Right.
What would be indicative of that on an x-ray besides shift of the mediastinum, tracheal deviation?
Technically, you would see like a more darker side, like basically here, because like the air would be darker. That would be collected.
So all this white stuff, what is that?
I mean, those bronchi.
Yeah, lung tissue, bronchi, I mean, there's fluid in here, there's lymph nodes here, there's pulmonary vasculature there. When you have a collapse of a lung, air is black on an x-ray. So you would look for an area that did not show any of these markings. These pulmonary markings, you should see them come all the way out to the edge here.
Right.
All the way out to the edge. So if you look at this superficially, you might say, well, it looks like both lungs are pretty fully inflated, right? But I'll point something out to you here. If you see, and this is kind of hard, I apologize from behind, there's a line here. I don't know if you can see that or not.
Well, I can see your pointer.
Yeah.
I can't see the
the line.
I don't know if you can see it. Right here, there's a line. And there's no pulmonary markings beyond that line. And if you follow that line, follow this line, and it's hard to see from back there, it goes right up here. So here's your pneumothorax. That's called a left apical pneumothorax. You can have a seat, thanks. And I apologize, it's a little bit subtle. Do we have light? Can you turn the lights down in here? Is there a light switch back there?
Automatic.
Oh, okay. Oh, it's automatic, okay. So anyway, up in this left apical area is a small pneumothorax. Okay, thanks. Small pneumothorax, left apical lung. And this person, I think, let's just see, 35, relatively young, and as mentioned, typically it's tall, thin people are more prone to develop spontaneous pneumothorax. And if you've had one spontaneous pneumo, you have an increased risk of having a second and a third. So a lot of these folks, once it's resolved, and if they have a second one, sometimes they need to have a procedure done to basically sclerose the lung, the lung to the pleura there. It's formed like a scar to keep it adhered. Now here's a more obvious case. This is what you were mentioning. This is tracheal deviation. There's so much pressure in the left side of this lung that it's pushing the mediastinal structures to the right. Every time you take a deep breath, there's air going here. This lung is completely collapsed. This is a life-threatening condition because of that profound hypotension, because of increased intrathoracic pressure. You're obviously going to have difficulty ventilating and oxygenating because you've basically suddenly created a pretty significant ventilation perfusion mismatch. Yeah, and this is something that trauma, or with or without trauma, if you don't address this pretty quickly, this patient can die in relatively short order. So this is one that you want